Welcome everybody to the February edition of the Sustainable Kidney Care Network webinars. These are hosted on the fourth Thursday of every month from 2 to 2:50 UTC to give everyone 10 minutes to have a little break before their 3 o'clock clinics and meetings begin. Last month, we were very lucky and grateful to have Tamara Glavinovich, nephrologist and vice chair of the Canadian Society of Nephrology's Sustainability Working Group, who delivered a fantastic overview of the state of sustainable kidney care in Canada. If anybody missed that talk, allow me to share my screen for a moment. The very best place to everything is our Kidney Care Sustainability Network, which is free to join. It's a fantastic resource. People post events, case studies, publications. You can see the upcoming events. And if we scroll down, we can see the recordings as well. So definitely worth signing up if you're not already a member. If I could just ask people to mute their mics, that would be appreciated. We do have a special announcement this month as well. As I'm sure most people in this room know, these webinars are in collaboration with KitNew Care, and which is a EU Horizon project that's reaching a really interesting part, really exciting part actually, of its 4-year cycle, where we are looking for associate pilot sites. So the QR code is up on your screen currently. If your site, your clinic, your hospital would like more information, it's a fantastic opportunity to get involved and really be at the cutting edge of what we're doing with sustainable kidney care. So give that a scan and contact for more information. Just a little bit of housekeeping before I hand over to Alberto. If people could mute their mics, that would be great. This is recorded and we will post it on our YouTube and within our network here. The format is a shorter presentation, around 20 minutes, followed by good time for discussion at the end. So please save questions to the end. If anybody in the meeting would like to be a future presenter, they have publications or whatever coming up that they'd like to present, do reach out to me and be delighted to facilitate that. And I will remind everybody at the end, but when we get to the discussion part, if people could turn their cameras back on, it really helps to make the discussion feel like we're all in the same room and facilitate that back and forth. So that is housekeeping. I will introduce our speaker, Professor Alberto Ortiz, who we are delighted to have with us today. Professor Ortiz he studied medicine at the Universidad Autónoma de Madrid in Spain, trained as a nephrologist and completed his PhD at Fundacion Jimenez, Diaz and UAM in Madrid, and was a postdoc researcher in molecular nephrology at the University of Pennsylvania in Philadelphia. He is head of nephrology and hypertension at the Fundacion Jimenez Diaz Health Research Institute and UAM, professor of medicine at UAM, renal science chair and distinguished member of the ERA, and coordinator of the Spanish Kidney Research Network. And in 2020, he received the ERA-EDTA Award for Excellence in Research. So we are delighted and very honored to have you with us, Alberto. I will hand over to you. If you would like to begin your presentation, that'd be great.
Okay, I think I'm sharing already.
Yes, perfect.
Yes. Okay, so thank you very much for the kind presentation and the opportunity. I have entitled this The Rationale to Combine Maintenance of Health with Decreasing Environmental Impact Through Prevention. So the key word is prevention. I have potential conflicts of interest to disclose because of my relationship with pharma companies. And so this, some of you may have seen this. There were videos that were very popular a few years ago. It displays a burial, in fact. So one of these ceremonies takes place in the world every 20 seconds for someone dying from chronic kidney disease. These are the latest data from the Global Burden of Disease study published in November in The Lancet. In fact, it is projected that by 2040, CKD will be the 5th global cause of death, and even in Western Europe, it's projected to be the 3rd one. As you can see, it's expected, the number of deaths is expected to increase by more than 30% adjusted by age, while ischemic heart disease and stroke deaths will be halved, and even diabetes deaths will be decreased. So chronic kidney disease is the worst performer across the cardiovascular kidney metabolic spectrum, and we should ask ourselves why. And maybe we cannot understand this because how is this possible? So if the kidneys fail, we have dialysis, we have transplantation, and they should be replacing kidney function and solving the problem. However, the main issue of kidney replacement of chronic kidney disease is not dialysis, but accelerated body aging. So currently, we have over 500,000 people on kidney replacement therapy in Europe. That's the whole population of Toulouse. And if we look at people on dialysis, the whole population of Cordoba in Spain would be on dialysis, or the whole population of York in the UK would be transplanted. So huge numbers. And we have failed all these people because we were unable to prevent their progression to kidney failure replacement therapy. So I was saying before that how is it possible if we have this kidney replacement therapy, people are still dying from chronic kidney disease? Well, first, we have an issue with these forms of kidney replacement because they don't replace all kidney functions. In fact, they do not replace for dialysis and replace suboptimally the key kidney function, which is the gerosuppressive function of the kidneys, the anti-aging function. In this regard, if we look at different ages at the start of kidney replacement therapy and the expected remaining years of life, and the gray dots are healthy people. Well, if you are 20 years old on dialysis, a man, your life expectancy is 36 years less than in the general population, 20 years less on transplantation, and much worse for women, up to 44 years less of life expectancy. So if we take into account that as you get older, your life expectancy decreases, we may conceptually translate the expected remaining life expectancy, a measure we are not very familiar with body aging. So a 25-year-old woman on dialysis has the same life expectancy as a 70-year-old woman in the general population. So conceptually, she is 25 years old chronologically, but her body is already 70 years old. And in fact, this is known since not so long ago. 3 years ago, the impact of diverse chronic conditions of biological aging was assessed, and CKD was the chronic condition that most accelerates biological aging. So as a mean, if you have chronic kidney disease, to the chronological age from your ID, your day of birth, you should add a mean of 6 years, but up to 15 years. So ID says 30 years old, your body is already 36 years old. And this starts very early on. And we can see it when we look at the consequences of a CKD diagnosis. So here we have for young people that is younger than 65, the risk in green, you don't have CKD, and the risk for peripheral vascular disease, arrhythmia, heart failure, stroke, myocardial infarction, all-cause death, cardiovascular death. And you can see that the heat map indicates that the risk increases, and if you are older, exactly the same. And the risk increases when GFR goes down, so when you accumulate uromic toxins, and this is easy to understand, but also horizontally when albuminuria increases. So why does the risk of age-associated conditions, biological aging, accelerate when albuminuria goes up? And we have some answers for that. So whenever you have albuminuria, this means that you have proximal tubular cells that are unable to engulf all that albumin that is being filtered by the kidneys. They are full of albumin, they have prototoxicity, and they lose some specific kidney functions that we do not measure usually in the clinic, such as the production of the anti-aging factor, the gerosuppressive factor clotho. So being able to measure albumin in the urine means that you have already lost this key kidney function, gerosuppression, despite you may still have normal glomerular filtration rate, which is the only kidney function that we measure in the clinic. And what are the consequences of losing clotho? Well, this has been very well studied in mice. As in humans, main source of clotho is the tubular cells. And if you lose them, if mice lose them, they die in their teenage year, in the murine teenage years, with accelerated body aging, with osteoporosis, cardiovascular calcification, left ventricular hypertrophy, cardiac fibrosis. That is the cardiovascular phenotype of chronic kidney disease. So you lose this single kidney function that we know it's been lost because you have albuminuria, and you already reproduced the cardiovascular phenotype of chronic kidney disease, even when glomerular filtration rate is still normal. And it's very well known that albuminuria is associated with an increased risk of death, even in older people. You see here, horizontal axis albuminuria, vertical axis absolute risk of death. The people with the most increased risk of death are the elderly. And please remember that nobody is born with an albuminuria of 1,000. So people who wish in the clinic with 1,000, previously they had 300, previously 30, previously 10, and previously under 3. And we have missed all these opportunities to diagnose early the condition and treat it so as they never reach 1,000 of albuminuria. Today, we diagnose chronic kidney disease when glomerular filtration rate goes down or albuminuria is above 30, but you can see that earlier on, the risk of death is already increased. And for example, if you have normal kidney function and you don't know your albuminuria value, you may already have 100 tickets for the lottery of needing dialysis and you don't know it. This is why we will be emphasizing today the need to know your albuminuria values, but this is an actionable item. You can treat this to decrease this risk of 100-fold higher needing dialysis, even when your kidney function is normal. Okay, so how does chronic kidney disease progress? Glomerular filtration rate is slowly from a normal of 120, and when it is below 60, we diagnose chronic kidney disease. But people do not get up one morning on Saturday and they have GFR 55. Previously, they have 60, 65, 70, 75, 80, 85, 90, and all those are missed opportunities to prevent chronic kidney disease. Okay, so when GFR is below 60, we diagnose chronic kidney disease, but we are late. But that time, out of the 2 kidneys, we have lost the kidney mass equivalent to 1, and this remaining kidney is damaged by the very same reason that took away the mass equivalent to the other one. And this is irreversible. You cannot recuperate this lost kidney mass. And then we can diagnose chronic kidney disease based on albuminuria. It also goes up from undetectable to over 30. And sometimes this occurs before losing kidney function. This is when we can diagnose chronic kidney disease earlier on and treat it earlier on. And this will be the focus of our talk. So as an example, this is a real case. We saw a couple of weeks ago, 70 years old, serum creatinine just above normal, glomerular filtration rate just below 60, proteinuria negative, but albuminuria was tested and it was high. As the patient has general malaise and serological evidence of kidney disease, a biopsy was performed, and you can see that half of the kidney was normal and the other half was already destroyed. So GFR below 60 means half of your kidney is already gone. You see here, larger magnification, this is normal, all the rest is abnormal. Okay, so this is the natural history of chronic kidney disease. GFR goes down, albumin goes up, and at this point, CKD is diagnosed. And in this individual, today, both thresholds have been passed. Okay, so this man, it could be me, around 60 years old, goes to the doctor, and the nephrologist says, we have good news and bad news for you, sir. Which one would you want first? Well, let's go to the good news. Okay, so, sir, you have 53 tickets for the lottery of ending up of dialysis. You see here, albumin above 30, GFR below 60, 53 tickets. Damn. And if those are the good news, what are the bad news? Well, the bad news is you will need dialysis if you are lucky, because you also have 3+ tickets for the lottery of dying prematurely before needing dialysis. Damn. But how is this possible? I come here every year, and you never told me there was any issue with my kidneys. Well, and there wasn't. You were on a green cell. You see, GFR above 60, albumin below 30, green cell, and the guidelines say I should only look at your face and do nothing. Okay, is this really true? Well, if you look the details of where this summary table came, when people have slightly decreased GFR, slightly high albuminuria, not yet meeting criteria to diagnose chronic kidney disease, they may already have 5 tickets for the lottery of chronic kidney disease. This is for the future. So in the future, real prevention of chronic kidney disease means preventing chronic kidney disease from developing. And this means identifying these people at very high risk and treating them. Okay, so let's do an exercise. Please pay attention. This exercise is called Who is Missing. So please pay attention. Traffic light, you know, in traffic light, the amber means action should be taken now, such as braking. So we have overweight and obesity, prediabetes and diabetes, high blood pressure and hypertension, pre-heart failure and heart failure, and a big black hole there. And each of these amber conditions means that you should start doing lifestyle if you are not already doing it, because you should have been doing lifestyle since your teenage years. But additionally, there are pills for each of these preconditions. And in CKD, we just wait until CKD has been developed, until people have 50 tickets for the lottery of dialysis to start doing something about it. And this year, the World Health, the WHO told us that you should do a better work of early detection and better prevention of chronic kidney disease and improve access to treatment. And KDIGO also developed this document emphasizing that the aim should be to maintain kidney health. So not to avoid dialysis that we should, but to avoid chronic kidney disease, which is a prior step. Okay, so this is what we understand now for intervention. We wait until kidney disease has developed, and then we treat chronic kidney disease, which is sometimes called secondary prevention. Yes, we are trying to prevent kidney failure, but people already have a lot of tickets for diverse lotteries because they have CKD. In the future, we would like to identify very high-risky people among those who don't have chronic kidney disease and perform primary prevention of CKD. Okay, so nephrology was born last century when we could treat kidney failure. Now we are treating chronic kidney disease. In the future, we should be preventing chronic kidney disease. So taking cues from over 2,000 years of Chinese thinkers. But preventing chronic kidney disease is for the future. Today, we should be trying to diagnose early and treat chronic kidney disease. And this is what you get based on clinical trials when you treat chronic kidney disease. In the horizontal axis, time to kidney replacement therapy, vertical axis, kidney function, glomerular filtration rate, when you start treatment. So if you start late, GFR 20, you still delay dialysis by almost 2 years. That may appear to be low, except if you are the patient, because these are nearly 300 sessions of hemodialysis, nearly 600 punctures with quite large needles. It costs society quite a lot, and it's environmentally unfriendly. But please notice the impact of treating early. When glomerular filtration rate is normal, you may delay dialysis by nearly 30 years. But how were these people with normal kidney function considered to have chronic kidney disease and enrolled in this trial because someone at some point tested for albuminuria? So testing for albuminuria allows you to start such early intervention with up to decades delay of dialysis or never needing dialysis. So this is the holistic cardiovascular kidney metabolic disease approach that the European Renal Association is promoting, an ABCD approach where albuminuria is at the same level as glucose. Albuminuria diagnoses a condition which is treatable with up to 5 different drugs according to guidelines. Diabetes, glucose diagnoses a condition which is diabetes, which is also treatable, and both treating albuminuria and treating diabetes prolongs a healthy life. Okay, so who should be tested for CKD? KDIGO in the 2024 guidelines lists 21 risk factors. So as you would understand, it is impossible for primary care physicians to go repeatedly over these 21 risk factors in the 3 minutes they have. So this is a recipe for failure to identify CKD. And moreover, the main risk factor is missing, which is the most important one, which is present, for example, in the Spanish guidelines, which is age. So if instead of going over 21 risk factors, you just focus on age, you will identify a much larger population that may benefit from albuminuria testing in a much easier manner, because at the top of the clinical records, you have the age. Okay, and this is the current practice in our catchment area. We have some people with diabetes in the catchment area. In a single year, just half have albuminuria tested. We have more people with hypertension, another risk factor. Just 1/3 have albuminuria tested. So as you can see, convincing all the primary care doctors that take care of these people with diabetes and hypertension that are not tested, that they should be tested, it's a very uphill work. And when you look at the older people, just 20% are tested for albuminuria. So we should make it easier for people to know their albuminuria, not just wait for an active intervention by primary care physicians who may or may not be aware of CKD. The current CKD diagnosis is just over 10 years old. So most practicing clinicians did not study the current concept of CKD and the importance of albuminuria. And moreover, I saw before this graph, please notice that chronic kidney disease in 25 years' time, and the people dying then from chronic kidney disease, now they are in their 50s and 60s, will kill more people than colorectal cancer and breast cancer. So CKD is on track to be a larger health burden than conditions for which there is universal population screening offered at certain age. So the question is, why not offer population-wide screening for chronic disease as it is done, for example, for colorectal cancer? So for this, we have to first acknowledge the obvious, which is not so easy. George Orwell told us to see what is in front of one's nose needs a constant struggle. And when we go to dialysis unit, we see older people. And in fact, the incidence of kidney replacement therapy increases exponentially with age. It is 200-fold higher for people 75 years or older than in teenage people. And this we don't acknowledge. Age is not among the risk factors for CKD according to KDIGO. However, when we look at the incidence and at the prevalence of chronic kidney disease in our catchment area, we see this. This is the life expectancy in Madrid women around 90 years. This is the mean age of chronic replacement therapy. And this is where we think people should be screened for chronic disease. So just before the incidence starts to rise, unlike 10, 15 years before the median age of kidney replacement therapy. So oncologists have recognized this. If you look at the National Cancer Institute webpage, advancing age is the main risk factor for cancer. You see here different ages, incidence of cancer. And yes, there are also other risk factors that should be avoided, smoking, alcohol, but the association with age has consequences, mainly the universal screening based on age. And as you can see, the risk of kidney failure follows the very same pattern. So again, why are we offering screening for cervical cancer, breast cancer, and colorectal cancer, which I very much agree with, but not for CKD, which is killing every year more people than cervical cancer. It is killing every year more people than breast cancer, and is on track to kill more people than colorectal cancer in the next 20, 25 years. So what we have done in Madrid we have this colorectal cancer screening, which is based on stool testing for blood. We are also offering urine testing for albuminuria. This exercise started 1 year ago. Over this year, the uptake has increased from around 15% to 25%. This is the same pattern we saw, for example, for colorectal cancer, breast cancer screening. Initially, people know about it, about the consequences, but slowly the screening is going up and up. Rodrigo Martinez Cadenas at our center has used this data. So the prevalence of uptake of the screening, that it is offered for free for all people in the catchment area from age 50 to 69, as is the colon screening offered. The rate of positivity, which is around 5%, and has estimated what would the environmental impact of treating these people versus waiting. And the good news is that this universal screening offered, the universal screening for chronic kidney disease, will allow early treatment, prolong healthy life, decrease the need of dialysis, and be environmentally friendly. And during the approximately 25 minutes that I have been speaking, around 75 people have died around the world from chronic kidney disease, and making an impact on this is as easy as offering a diagnostic test that costs 0.3 euros and can lead to early treatment, longer healthy life, and less environmental impact. Thank you very much for your attention, and now I'm open for questions.
Thank you, Alberto. That was a fantastic presentation. Superb. I'll just remind everyone to, if you can, please do switch on your camera for the duration of the discussion. It just really helps with facilitating a discussion, so that'd be appreciated. Agnieszka, I'll go to you first.
Professor Ortiz, amazing presentation. I'm really inspired by that, and I fully are with you for the importance of prevention of such a horrible disease like chronic kidney disease that can be preventable, but the moment appears, it's irreversible. Because we are living in the world of comorbidities, diseases arising from type 2 diabetes, obesity, hypertension, and also age, right? Related, thanks to what you actually show on your presentation. My question here is, what do you think is the primarily reason why GPs are not testing for albuminuria? Is it because it's like poor awareness of that? That's like lack of medical education, maybe lack of CME points? And the second question is, what do you think about the clinical algorithm that help us diagnosing these conditions also, and would help also with increasing rate of testing for albuminuria? Thank you.
Okay, so thank you very much, Agnieszka. I think it's complex with primary care physician, and there are several reasons. And mainly have to do with inertia. So when albuminuria was initially described in the 90s, it was a novel and expensive test. So it was limited to diabetes. Now it has become more widely available and cheaper, but people are not aware of that. And I know that in private practice, laboratories are charging €5 for albuminuria, when in fact the cost is around €0.3. But as nobody is aware, so this is first, the feeling that this is for diabetes and it is expensive. Second, as I said before, the current concept of chronic kidney disease, based on both a specific threshold for albuminuria and GFR, dates from 2012. So most practicing physicians, they never studied it and they never saw it during their specialty. And there are not so many physicians that go to meetings and to educational opportunities. And the older you are, the less you go. So many have never heard of this. Then primary care physicians, they are overwhelmed. So I don't know, in other countries, in Spain, they have 3 minutes per patient, and things as minor as the number of clicks they have to make is important. So we discovered that in some GP surgeries in Madrid, the arrangement with the local hospital is that they had to do a lot of clicks to ask for albuminuria. It was not included in a one-click hypertension labs, for example. So we have been working on that, and then they are some conditions are prioritized. I was reading the news recently that in the UK, primary care physicians will get bonuses for prescribing GLP-1 receptor agonists. So in Madrid, for example, they get bonus if they assess very well diabetes or cardiovascular risk, but there was no bonus for CKD. So from starting this year, they will have it. Then there is peer pressure and the patients. Patients come to the clinic and they ask about their cholesterol. They don't know what's albuminuria, so we should make sure that they know. So providing this universal screening will favor that people become familiarized with this. So someone receives and have been invited to test for albuminuria, what's this, and tells his neighbors, his friends, what's this, albuminuria, what is, and then he start talking and they realize that this is important. So I think there are all those reasons. And the problem with primary care physicians also is that they are bombarded by specialists for algorithms for CKD and Alzheimer and pulmonary disease, and they cannot cope. So this is why we think offering albuminuria testing together with colon cancer testing, I mean, in the same act that you collect a piece of poo, which is difficult, you collect a piece of pee, which is easy. And it is not invasive. Some may say, and why not GFR? Well, why not GFR? It is more complex. You need to draw blood. And in our catchment area, every year, 50% of the population have GFR. They go to the doctor for one reason. Over 5 years, 80%. So what we are missing really is albuminuria. That less than 5% of the catchment area gets albuminuria testing. So I think let's make it easy. It's important to create awareness in primary care physicians, but instead of trying to push each individual primary care physician, if you offer this to the whole population for free and linked to ongoing early diagnosis programs, it will be easier for everybody. Thank you. Actually, we have done something else. So we have in our biochemistry lab, we have changed the dipstick strip. Before it had 9 items, now it has 11, and it includes albumin and creatinine. So now every urine that enters the lab. So when doctors ask for dipstick, they don't specify what elements of the dipstick they are asking for. So we have changed the strip. It is the same cost, and we do semi-quantitative albuminuria, creatininuria in every sample. As the dipstick also provides information on urinary tract infection, if there is evidence of urinary tract infection, it stops there. But if not, before the urine comes out of the machine, if the semi-quantitative urinary albumin-creatinine ratio is above certain value, the machine performs the quantitative test. Okay, so now we are offering albuminuria testing to every urine that enters the hospital at a lower cost for the hospital than before, when we were using quantitative albuminuria in the patients that albuminuria was requested. Again, making it easier for everybody.
Definitely, making more accessible and also incentivizing, also like decreasing costs, and you can actually expand the coverage of biomarkers to measure there. Absolutely. Very smart way. Congratulations.
Thank you.
And but maybe the second question around, are you aware of any type of clinical algorithms like KFRE or any other ones that you are using using in the practice to help also then using albuminuria, because the ACR testing is also mandated there, and then what's your thought on that? Would that help as well?
Yes, so in fact, in some places they don't allow to complete these algorithms if you don't put albuminuria in. In my hospital, we cannot continue the writing in the electronic health records until we can inserted the weight and height. So what are people doing? They are putting there any number. So we cannot wait the patients in our offices. So we have to ask the patient, and if the patient doesn't know, you are stuck. So people put any number. So I think there is this risk. So if you make it like compulsory to insert albuminuria to continue, you have 3 minutes. Yeah, put just anything in there.
Thank you.
Thank you.
Thank you. Any other questions? Francis.
Hey, this question for everybody, I suppose, is, do people have any experience that when you include the fact that it protects the environment, that the message about prevention reaches more people or creates additional interest in that message?
So we don't have the experience, but we hope so. So Rodrigo, which has done these quantifications on the environmental impact, the moment the paper gets accepted, we plan to do a news release. And if you talk about the kidney, so journalists, they are not usually so much interested, but we hope that through the environmental angle, this will be picked up, but hopefully for national newspapers or even the TV news, which in Spain it is still quite popular, unlike in other countries.
Thanks.
We'll keep you posted.
Yes, I know. Yeah, I'm excited to hear that. I don't know if anybody else has experienced, because I've seen the message being included like around World Kidney Day. I know that EKPF, the European Kidney Patient Federation, have put out statements about sustainability as being important and things like that. But I haven't heard from the other side how people are receiving that message.
Ray, go ahead.
Yeah, I think one of the problems is that the general awareness about kidney diseases is very low. So if you want to talk to policy makers, and you have this message about the environment and the kidney, it's already a problem to explain how the kidney works, and then they have more problem to understand dialysis, and they have even more problem to understand the environmental impact of dialysis. So at least at the European level, we are already hammering on the same nail for 4 or 5 years, but it doesn't work very well. And as you know, at the last elections, there was a shift more to the extreme right, so that the Green Deal was there, but it has been weakened. So I think the only solution is to repeat, and then also to explain. And fortunately, the awareness is growing, but it's growing slowly. I think it's a task for all of us to create more awareness.
Yes, I think we should also try to present the information in a different manner. For example, the WOW number, 850 million people with CKD, it's very large, but the mind cannot easily differentiate from 80 million or 2,000 million. It's very big. But the fact that every 20 seconds someone is dying from chronic kidney disease, you do know what's a death, and every 20 seconds looks huge. So yeah, so I think we should be providing these messages too, and also I think we should promoting the message that chronic kidney disease is not about dialysis. It is a accelerating biological aging. So now you see aging is everywhere in the news, in society, etc. It's the main concern of many people, mainly the millionaires, no? How they are going to die like everybody else when they have so many millions. But this makes it permeate society. So I think we should be linking chronic kidney disease with biological aging. And there is in fact evidence for that. So we know that gerosuppressors, anti-aging compounds are produced. Clotho is very well known, but last summer, the Cell Journal published that betaine is also produced by the kidneys, and it is responsible for the anti-aging impact of exercise. So I think we should be pushing this CKD is accelerated body aging, and everybody can benefit from protecting their kidneys, and you know that the anti-aging function of the kidneys is failing when you have albuminuria. We have Borja Quiroga is a young Spanish nephrologist that has, in fact, already 2 books on the kidney, because the first one was so successful. And he's been going down the rounds in radio and TV on the anti-aging function of the kidneys, Clotho, how important it is. So shifting their narrative from dialysis, which is for a few people, and people are not don't much understand. Likely it will not be me because it's only a few people, to aging, which everybody is concerned about that. Thank you.
Great.
I have another question. If CKD is aging, which is obviously true, and a CKD occurs also in people who are younger than the threshold for albuminuria of 45, does it then not make sense to extend the population to test to somewhat earlier, let's say 35?
Yeah, I fully agree. I mean, I fully agree. The problem is that age is not in KDIGO. Spain has age in the national guidelines at 60. We are now pushing for 50 because of its colon carcinoma. So I would agree that earlier, and I think once we spread the word and people become, we have had very interesting results from this universal screening. We have been diagnosing kidney cancer because albuminuria appears to be up when you have a tumor that is necrotizing and it's bleeding. So when people realize the benefits and where they start going out, I think we may be pushing for earlier. In fact, I think we need, and and I think there is, but it's not like enforced, healthy adult screening. So when you are a child, you have this healthy kid visits to the pediatrician, but once you turn 18 years old, you wait until you become ill, and we have so many ways to prevent. So I think we should be promoting this healthy adult for cardiovascular risk factors, at least cardiovascular metabolic risk factors. And also people learn about lifestyle after they have developed a complication in their 50s or 60s. And so first, when you read guidelines, what you first to do? Lifestyle. I mean, how come when you are 60 years old and you have a myocarditis, you start lifestyle? You have started 40 years earlier. And this is where these healthy adult GP visits make sense. Education on lifestyle since before having the problem.
Thanks, Alberto. Probably have time for one last question. This might mean I get a chance to ask my question if no one puts their hand up.
You have a chance now.
So I was, that's a fantastic presentation. Really enjoyed the discussion. I particularly like thinking reframing CKD as aging. I think that's really powerful. And I also really like the holistic approach. So rather than things being siloed, here's cardiovascular, here's metabolic, here's kidney, actually sort of thinking of things holistically. And I was going to ask a question on, oh, I see Gloria. I'll ask a quick question and then Gloria can get a question in afterwards. I wanted to know more about the dipsticks that you brought into the hospital. It sounds like such a triumph. And I want to know why that isn't being replicated everywhere if it's, you know, as easy and not adding any cost.
Yeah, so the hardware in our hospital is from a Japanese company, and they have been working very hard on this. So we got the idea from a hospital in Alicante, also private management, and they were offering albuminuria to more people, and they did this estimation. They found the cutoff where you miss only 1% of the people with albuminuria above 30. And apparently it cannot be replicated by every hardware of dipstick. Okay, but at least for this specific company, it appears to be working nicely.
Interesting. Thank you. Gloria.
Thank you. Can you hear me well?
It's a little bit low.
A little bit low. Okay. Increase the volume. Okay. Sorry. Unfortunately, I couldn't join the whole session because I was in clinic. You said that every 20 seconds someone is dying from CKD. I have to say, I honestly didn't know this. Where can I find this info and how can I discuss this with my patients, please?
Okay, so it's the Global Burden of Disease publication in the Lancet on CKD in November. They provide the number of people that die every year from CKD. You divide it into the number of seconds in the year, and you get one every 20 seconds. So in order to avoid the people doing this math, we have just we have a paper on NDT, which just has been accepted with that title. Okay, we explain where this comes from, but it's in the title, so as it is easy to disseminate.
Fantastic. When can I access this paper, please?
I think I can send to you I can put here. I think no, I cannot because I was not the. It was Paddy Mark who submitted it, so I may not have the final version with the referees, but it will be very soon. So I will send to Furat perhaps as soon as we have the proofs.
Thank you.
Please do. And I would be delighted to share it and get to plug once again the Sustainable Kidney Care Network, which if people here aren't familiar with, then definitely join. It's free. It's kept up to date with papers, with studies. And a last plug for Kidney Care's call for associate pilot sites. It's a really exciting time to join that project. So that brings us to the end of the meeting. Alberto, thank you so much for a brilliant, truly brilliant presentation. Thank you everybody for joining. Thank you for the stimulating discussion.